Imaging of bone tumors. Number 1. We know all about the anatomy: epiphysis, epiphyseal plate, periosteum, cortex, and marrow. We know that the pathology depends on the tissue of origin. If it is undefined, it is simple bone cyst, and if it is vascular origin, it is aneurysmal bone cyst, hemangioma, and the malignant form is angiosarcoma. If fibrous tissue, it will be fibrous cortical defect and non-ossifying fibroma, and the malignant form is fibrosarcoma. If it is cartilage, it's chondroma, chondroblastoma, and the malignant form is chondrosarcoma. And if it is coming from bone, it is osteoma, osteoblastoma, osteochondroma, and the malignant form is osteosarcoma. Mind you that in simple bone cysts, this is something developmental, as if you are stretching marrow, so defects appear, and the defect represents a cyst. In vascular tumor and fibrous tumor, there is no cells to ossify or calcify, so the matrix is clear. But in cartilage, there is specific pattern of calcification within the tumor, which could be flex arcs and rings or mottling, and this is called chondroid matrix. And of course, if the tissue of origin or the cell of origin is bony, it will result in formation of blotches or patches or masses of bone within the tumor. If it is coming from the marrow, we have decent or benign forms like eosinophilic granuloma and giant cell tumors, and we have the malignant forms including the Ewing, the lymphoma, the multiple myeloma, the leukemia, and malignant fibrous histiocytosis, as well as fibrosarcoma. This one represents the location of the tumor. If it is within the marrow, you expect that it could be benign, like simple bone cyst or aneurysmal bone cyst, or it could be malignant as round cell tumors. If it is like number 1, parosteal, it is usually a parosteal osteosarcoma or parosteal fibrosarcoma. If it is a corticomedullary lesion, we include here chondromyxoid fibroma, for example. And if it is periosteal, it is usually related, periosteal and subperiosteal, it is usually related to osteoma and similar lesions. The pattern of destruction will give us the outline. If the pattern of destruction is aggressive, the outline will be lobulated, infiltrating, permeating, and this indicates malignancy. If the pattern of destruction is less aggressive, it will give a chance to have a well-defined margin, and this will be benign form. According to the aggressiveness of the tumor, it will affect the periosteal action. If it is something rapidly growing, it will destroy the cortex, and thus will give us the well-known Codman triangle, up and down. And if it is giving a chance, it will give a layer of periosteum, then layer of soft tissue, and layer of periosteum, and layer of soft tissue. It will give the onion peel. Or if there is growth along the vessels, it will give the sunray appearance. All these three on the right are malignant forms, while these two on the left with continuous periosteum are less aggressive. and this can appear in any of the lesions showing sclerosis or showing sclerosed margin. To differentiate between benign and malignant, we have the well-defined outline, the sclerotic border, the less aggressive periosteal reaction, which is continuous, and there is no soft tissue extension. This will be benign, and the reverse, of course, will be true for malignancy. The most important point is that the extension into soft tissues, that is extraosseous spread, the aggressive periosteal reaction, including the sun ray, Codman triangle, and onion peels, and the loss of the sclerotic border with ill definition of the margin. This will constitute the characters of malignancy. If we are doing MRI for a bone tumor, we can get a chance to investigate the intraosseous as well as the extraosseous spread, joint invasion, neurovascular involvement, and lymphadenopathy. High T1 signal could be seen in fatty tissue, blood, and melanin. So you expect to find it in lipoma, hemangioma, hematoma, infarct, Paget disease, and melanoma, while low T1 signal is seen in osseous and soft tissues if there is calcium or fibrous tissue or blood or altered blood or melanin. So we can get it in calcium, fibrous tissue, hematoma, lymphoma, gout, pigmented volvinodular synovitis, melanoma, and so on. The cartilaginous tumors in MRI, as we know that there is something called chondroid matrix, which is formed of flex, arcs, rings, and mottling. This calcification will show as low T1 and T2 signal, while tumor masses itself show high T2 signal, and septation in between could be fibrous, could be calcific, and thus it is low T2 signal. If we compare a chondroma with a chondrosarcoma, there is no much difference in MRI. We should depend on the malignant characters, extension or extraosseous extension, and the appearance of the surrounding periosteum and the cortex. Simple bone cyst, as we said, it is a developmental defect while the bone is stretching, while the bone marrow is stretching. So usually it is within the marrow. Of course, it should be within the marrow. And if it happened, it appears as a defect within the marrow. This gives weakness for the bone, thus susceptible for pathological fracture. It is discovered incidentally because it is not a tumor, it is something developmental, and it occurs in teenagers, usually in long bones. Proximal humerus and proximal femur are more commonly affected, but even the os calces can be seen involved in such a case, in such a condition. Simple bone cyst. Simple bone cyst is not a tumor, no expansion, we can say no much expansion. Cortex is thin, and we can see within the tumor some septa, but there is no matrix calcification. The origin of this is something developmental due to stretch of the bone marrow. It's asymptomatic, teenager, 10 to 20, males more affected than female, usually presenting with pathological fracture. It can affect long bones, distal tibia, proximal femur, and it can affect humerus, of course, and it can affect the os calces. Here there is a lesion, simple bone cyst at the proximal femur, showing as any cyst, T1 low intensity, T2 high intensity, minimal expansion, but thinning of the cortex is evident. This results in weakness and maybe pathological fracture. When the lesion is blowing out of the bone, that means it is an aneurysmal bone cyst. It starts in the marrow again, and it results either in central or eccentric expansion with marked thinning of the cortex. The cortex becomes very thin. You cannot sometimes follow it in the plane or in CT, but the lesion as a whole is contained, is something of well-defined outline. It can reach up to 20 centimeters in diameter, and most of lesions are below 20 years of age. And the main feature is that it's formed of blood pools. So we can have the fluid levels, and the fluid levels are due to blood sediment and supernatant serum. We can classify it into central and eccentric, but this can involve the entire bone or being only subperiosteal and sometimes penetrating, and penetration here is indication of cortical thinning. And fluid levels is mostly seen in aneurysmal bone cysts, but sometimes giant cell tumors and fibrous dysplasia can give the same appearance. Aneurysmal bone cysts can result as a secondary lesion, as in giant cell tumor. It can change, and in this condition, we will get an aggressive, active, recurring tumor. If you compare an aneurysmal bone cyst with a simple bone cyst, the simple bone cyst is central, with no or little expansion. The chondromyxoid fibroma is eccentric, and in chondromyxoid fibroma being containing chondroid tissue, it will result in matrix calcification, either flaky rings or curved lines or mottling. Here in chondromyxoid fibroma, the cortex is definitely continuous and intact, and the main lesion is bulging into the bone, into the marrow. While in aneurysmal bone cyst, there is thinning of the cortex, and the main lesion is bulging outside the bone. There is no fluid levels in chondromyxoid fibroma. In telangiectatic osteosarcoma, which is a malignant process but with little bone formation due to aggressiveness, it's mainly forming soft tissue extension. If we compare it with aneurysmal bone cyst, even if the cortex is not continuous, but the lesion is contained, is well defined in aneurysmal bone cyst. Now, giant cell tumor is reaching subchondral bone, but aneurysmal bone cyst, by definition, is usually limited by the epiphyseal plate. This lesion, osteolytic lesion, is seen expanding the proximal tibia and limited by the epiphyseal plate. And this is an example of aneurysmal bone cyst. Again, if you see the os calcis, its inferior margin is bulging down, and that is blowing out tumor. It is again aneurysmal bone cyst. The matrix in both is not calcific. The cortex in both is markedly thinned, and these are the characters of the aneurysmal bone cyst. Multilocularity and blood pooling result in fluid levels. T1 on the left, T2 on the right. The supernatant fluid is low intensity in T1 and is high intensity in T2, while the blood ingredients sedimenting are giving low intensity in both. Similar lesion involving the pedicle and the vertebral body, aneurysmal bone cyst showing multiple fluid levels, and here the oscalces on the left before and on the right after treatment. Here is another aneurysmal bone cyst with expansion, thinning of the cortex, and limitation by the epiphyseal plate. This one shows that a lesion at the right superior pubic ramus with soft tissue tumefaction, pushing the gas shadows to the left. This is an aneurysmal bone cyst of the superior pubic ramus and the acetabulum, pushing everything to the left, and we should consider that the lesion is well defined because the fat planes are intact, although the cortex is not followed because of the marked thinning and rarefaction. Here it is with fluid levels, bulging into the pelvis, true pelvis, thinning of the cortex and bulge and fluid levels. T2 weighted images showing hyper-intense lesion, and here we get the fluid levels again in T1 weighted images. Now, fibrous tissue tumors. Fibrous tissue tumors could be, as we know, fibrous cortical defect. And to understand this, it is something similar to simple bone cyst. Simple bone cyst is a defect in the marrow due to stretch, and fibrous cortical defect is a defect in the cortex due to stretch. And both are asymptomatic, and of course, in simple bone cyst, the lesion weakening the bone is resulting in fracture. But here in fibrous cortical defect, there is no fractures, and it heals spontaneously. In non-ossifying fibroma, the tumor is evident. There is something bulging into the marrow, but well sclerotic, well defined, and the cortex around is intact. Of course, if you do MRI, it will show low signal intensity around due to the fibrous tissue, but the center sometimes is hyper intense in T2 weighted images because of the edema. It can reach up to 7 centimeters in diameter. This is an example of fibrous cortical defect, while this one is an example of non-ossifying fibroma with the fibrous tissue showing as low intensity around, and centrally there is some edema. Here is typical appearance of the non-ossifying fibroma with the intact cortex and the bulging tumor into the marrow with sclerosis. Similar lesion. Now, here we have the same appearance as non-ossifying fibroma, but there are some differences. It's more extensive, and it is showing internal calcifications. But they are the same as regard cortical intact and bulging into the marrow. So, both are fibrous origin. Chondromyxoid fibroma has additional chondroid matrix and myxoid tissue. Both show intact cortex. Both show bulging lesion into the marrow with a sclerosed margin. In non-ossifying fibroma, it is small. The chondromyxoid fibroma is extensive. In non-ossifying fibroma, the matrix is clear. In chondromyxoid fibroma, we can find internal calcifications as flex, arcs, rings, and mottling, and these differentiate both. If treated, it will appear as that one on the right. So this one is a chondromyxoid, cortex intact, minimal expansion. The main lesion is bulging into the marrow, and similar to that of the non-ossifying fibroma, it is well defined, but showing internal structural calcification. Internal calcifications. Rings, arcs, flex, and mottling. Fibrous dysplasia is not a tumor. It is a dysplasia, could be monostotic, could be polystotic. The monostotic form could be confusing because sometimes it reacts like a tumor in appearance, in morphology. So that's why we put it here. It can affect any part of the body. One phalanx, forearm, upper arm, the whole limb, the whole lower limb, half of the body on the right, half of the body on the left, upper half, lower half. Even the face can be affected, and the mandible especially. The ribs are subject to fibrous dysplasia, and the clavicles are also involved. Usually it appears in young age, 5 to 20, and simply it is a long-standing disease, long involvement in a long bone. Minimal expansion with ground glass appearance, skeletal deformities, and pathological fracture. To understand fibrous dysplasia, we should know about the key points. The key point is replacement of bone by fibrous tissue, and the second key is the presence of dystrophic calcification. So if you have dystrophic calcification in a homogeneous pattern, it will result in ground glass appearance. If it is sporadic, it will give the focal increased density, whether longitudinal or as patches. And as regard the fibrous tissue can cause expansion within the marrow on the expense of the endosteum, and that's giving us the lucent areas with what we call endosteal scalloping. Of course, fibrous tissue will result in a weak bone, and weak bone can be bowed, deformed, or can result in pathological fractures, and pathological fractures will heal with unhealthy tissue due to underlying fibrous elements. Pseudoarthrosis can result. This is the whole story of fibrous dysplasia. On the left, we can see that the bone lost its waist, the cortex is thinned, there is ground glass appearance that denotes homogeneous dystrophic calcification of the fibrous tissue. Weak bone result in fractures which heal with unhealthy pattern, either with deformity or with pseudoarthrosis. On the right, the two images for the femur and tibia show multiple lucent areas representing fibrous tissue with some minimal expansion and endosteal scalloping, and also show longitudinal bands of calcifications or flaky calcifications in the distal tibia, denoting the disease process. And here, lucent large areas with endosteal scalloping denote fibrous tissue growth on the expense of the marrow and thinning of the cortex, resulting in weak bone and bowing. This one, if in young, consider fibrous dysplasia. If in old, consider Paget disease. Here we can have that the marrow is lost it is due to ground glass appearance or homogeneous calcification of the marrow. These two examples of lucent areas growing on the expense of the cortex and causing minimal expansion, loss of the width of the bone on the right, and bulging on the surface at the proximal humerus, both are due to fibrous tissue replacement with endosteal scalloping. On the left there is bowing and there is stress fractures, and on the right there is pathological fractures showing pseudoarthrosis. Mandible involved in fibrous dysplasia is cherubism. This pelvis is showing a lot of focal foci of lucencies in a young baby, in a young patient, denoting that we are dealing with fibrous dysplasia. On the other way, if you find these changes in an old, please consider deposits. Fibrous dysplasia foci affecting long bones. Thank you. Imaging of bone tumor number 2. Going to osteochondroma, which is the most common benign skeletal neoplasm, up to 50% of benign bone tumors are osteochondromas, affecting both sex and usually representing in the second decade, and 50% are affecting the lower limbs, mostly around the knee. Metaphyseal, usually oriented away from the joint. That means the direction of the tumor or the longitudinal axis of the tumor is directed towards the elbow or from the knee. That's why we say, to the elbow I go and from the knee I flee. This is depending on the growth. The marrow space of the host is seen flowing into the lesion. It's extending into the lesion. There is cartilage cap, usually seen in MRI, and there is 1% risk of chondrosarcoma. So if you have one lesion, there is 1% risk, but if you have more than one lesion, you multiply the number you have by 1. 9 lesions will give 9%, 10 lesions will give 10%, and so on. It could be sessile or pedunculated. This is the appearances, something showing continuous marrow into the lesion and is directed from the knee. From the knee I flee. If we have a lot, this is multiple, or what we call it achalasia, multiple exostosis. The problem in this type of tumor is the deformity, the skin bulges, and the affection or stretch on nerves and vessels. And of course, on the top of the list is the sarcomatous change. Being osteochondro, that means there is chondroid tissue. It can present the famous flex, arcs, and rings, and mottling of the calcification within chondroid tissue, as in this case. See the skin bulge and muscle stretch, muscle weakness, muscle atrophy, and the same can occur, can result in nerve stretch or vascular block. It's another lesion. Here we can notice that the soft tissue around is dense on the image, the lateral view, and density of the tissue, rapid growth, warming of the skin, dilated veins, change of the rate of growth, all should direct your attention to malignant transformation. Similarly, this one with the soft tissue density around denote involvement, infiltration, and this is the cartilage capped calcification seen. Osteochondroma away from the knee with soft tissue density around denoting malignant change. Similarly, this one with soft tissue density around thickening denoting malignant change. Same, you can see the lesion, and posteriorly it is interrupted cortex, and there is soft tissue infiltration around denoting malignant change. Now, chondromas is another tumor, benign tumor, forms about 10 to 12% of all benign bony tumors, typically again between 10 and 20, and a lot of them occur in the hand or around the knee. They are benign, well-defined, expanding. The cortex is usually intact, no periostral reaction. The matrix calcification is characteristic of cartilaginous tumors, flex, arcs, rings, and mottling. And minimal calcifications are seen clearly by CT. The CT can define minimal calcifications. These are examples of chondroma, which we call it enchondroma, because it is inside the bone. And if you remember the calcification in a fibroid, it gives something similar to that image on the right, mottling. Mottling, calcification within the bone, within the marrow, some expansion, some cortical thinning, but no destruction, no periostral reaction, and there is risk of circumstance change. That's why any chondroma should be removed, because of this risk of being changed into malignant process, chondrosarcoma. MRI, the low intensity flex represents the calcification. You agree with me that the lesions are evident, but their outline is not evident. And that is the problem. That's why any chondroma should be treated by removal for fear of being malignant or changing into malignant process. Here are different images for the chondromas. The matrix shows the low intensity flex of chondroid calcifications, and the tumor itself is T2 hyperintense because of edema. Different images, axial, coronal, and sagittal. Now going to the chondroblastoma, which is something different. It affects the epiphyses and the metaphyses. It is epiphysio-metaphyseal. Epiphysio-metaphyseal pattern is characteristic for chondroblastomas. This lesion here is involving the metaphysis and the epiphysis, well sclerotic, well defined sclerotic margin. It's chondroblastoma. But notice that if this chondroblastoma occur in the vertebrae, it can give another appearance. All of these are chondroblastoma, epiphyseal, metaphyseal. The usual site or the common site is the humerus. And being chondrogenic, there is low intensity flex within the tumor. Now going to osteomas. Osteomas usually arises in the skull or flat bones, generally small, sometimes multiple. It can occur in the nasal sinuses. Here it's occurring in the frontal sinus. And here it is outside, so it can result in a bony mass into the cranium from the inner table, or outside the cranium from the outer table. Now coming to the osteoma, components, pattern in different bony parts. That means you should know the components and you should know the pattern in different bony parts. The component is an osteoid tissue which is aggressive, growing, and initiates reaction around. But this reaction depends on the bony parts in which it arises. If it arises within the marrow, there is no much bony reaction, while if it occurs near to the periosteum, there will be intense periosteal reaction. Here we have an osteoid osteoma with much periosteal reaction. Of course, if there is chronic osteomyelitis, it can give similar appearance, but you should be aware of the hypodense nidus within, like that. This one is a 1 centimeter reducent vascular area, the nidus, surrounded with intense sclerosis and cortical thickening. Of course, the isotope study can show it. Clinically, something evident that the patient complained of pain at night, which is relieved by aspirin. And these are different images within the CT, the same appears. Now, we agree about the nidus, vascular, osteoid, but what about the central part calcific within? This means that the central part is now quiescent and the peripheral part is the aggressive one, is doing the work, and the central part which is quiescent becomes calcific. Here, central calcific, then the active nidus, and then the periosteal reaction around. Osteoid osteoma in acetabulum. Here in a pedicle, resulting in sclerosis of the pedicle. Isotope study shows the hot spot, and the CT shows the central quiescent nidus being calcified, surrounded with the active nidus as translucency, and then sclerosis around due to stimulation of the periosteum. Similar lesions, noted that the cortex on the left side in the MRI is markedly thickened due to periosteal action. Here a sclerotic pedicle denoting osteoid osteoma. But they have another subject called osteoblastoma, and it is similar to osteoid osteoma, but the difference is the size. If the size is more than 2 centimeters up to 10 centimeters, it is an osteoblastoma. It usually occurs in vertebrae and in the humerus extremities. And if it occurs in the vertebrae, it is, of course, as most of the bone lesions occurring between below 20s, and that means that we will have affection in a young. The vertebral lesion will result in deformity. So, as a rule, a deformed vertebra in a teenager is considered osteoblastoma till otherwise proved. And in the extremities, it keeps the similar changes like osteoid osteoma. That means there is a central nidus, but here it will be larger than 2 centimeters. There in osteoid osteoma it is about 1 centimeter. And the periosteal reaction around will be more severe, and the extent of the lesion will be longer. Now here this one is showing deformed sclerotic vertebra due to osteoblastoma, and similar changes here. The osteoid tissue is aggressive and no chance to form central calcifications. So the difference between osteoid osteoma is the size, 1 to 2 centimeter in osteoid, and more than that, up to 10 or 12 centimeter in osteoblastoma. Central nidus may show calcification in osteoid. It's not showing any calcification in the osteoblastoma due to aggressiveness. Number 3, the soft tissue is more in osteoblastoma, and the reaction, of course, will be less because of the rapid growth, while in osteoid osteoma, the reaction is more sclerotic, more evident. If it occurring, the osteoblastoma, if occurring in vertebra, it will cause deformity of the vertebra, while the osteoid osteoma usually occur in the pedicle, resulting in sclerosis of the pedicle because there is a chance for a reaction. These are the main differences between the two. Here is an osteoblastoma which have the time to grow with minimal periosteal reaction, with minimal bone reaction around. It results in something expanding lesions in the pedicle or in the spine, and even can occur in the pubocremi. But as we said, the main lesions are seen in the humerus and in the vertebrae. These are examples of osteoblastoma at the knee. Mainly osteoid tissue surrounded with some sclerosis. This is an osteoblastoma, or a differential diagnosis can be aneurysmal bone cyst. Both are osteolytic, expanding, blowing the bone with thin cortices. Thank you.